we have our guest speakers are here and ready for us. Our first presenter is Dr. Anna Nash. She is, I actually just met her for the first time tonight, but she works with Dr. Moreno. For those of you who got to hear Dr. Moreno speak at the sex conference, they work together, they're colleagues, and so Dr. Nash was recommended by Dr. Moreno, and we're really excited to learn from you, Anna, because she talks about sexual health. She helps patients with sexual health dysfunction. She works with menopausal patients and is just super passionate about empowering women to live their best lives. And we all know that sometimes talking about these topics are very uncomfortable and can be kind of taboo in certain cultures. And so really excited that Dr. Nash and people like her are out there like advocating for us women with female bodies. And yeah, so she's gonna present and then leave some time for questions and answers at the end. So please welcome Dr. Nash.
If you guys think I need a microphone, let me know. I feel like this room is got good acoustics. So I am passionate probably about two things in particular in terms of my career path. Women's health, especially menopause, is a predominant part of what I do, and sexual health also. And of course, there's a big intersection between all of these things. And, you know, all of us women will eventually age and hit menopause. All of us are going to bump up against, you know, sexual health concerns at different parts of our lives. I want to leave, remind me, Allie, how much time I have. Do I have 45? I want to mostly have a lot of time for you guys to ask questions. I did my presentation tonight. Camille had me put together more about menopause and how the intersection between cancer and menopause impacts women. But I am very comfortable presenting about sexual health too. So if you guys have questions related to either of these things, don't hesitate to ask, because I feel like they are both equally important. But just honored to be here with you guys tonight. I feel like I might not know any of you individually, but there's a lot that you know about a group of cancer surviving women. And it is not easy to face the challenges that you have faced. So that courage, I know, is inside of each one of you. And passion then for sharing the experience that you've had with other women, and just that the sheer bravery of it, honestly, is just so inspiring to me. And I hope, you know, in my clinical practice, that I am living up to the same caliber of women that I know that you are, so that I can provide the needs and meet the needs of each of you. So I just wanted to start by doing a short slide presentation. I also have a slide presentation about sex, so happy to share anything and everything that you guys are interested in. So I've noticed that this group of women is on a lot of menopause platforms. So midlife women and experiencing, you know, all these changes. So menopause, obviously, definition-wise, it's just the end of reproductive years. It's just that transition between when a woman has functioning ovaries and when her ovaries retire to Florida for the rest of forever, and the cessation of menstruation. So there's different types of menopause. People don't always know that, but obviously natural menopause is what most women will go through. It's just the natural time of life. Average age in the United States is 52. And when the ovaries will stop functioning, their normal reproductive duties, and those cycles will end. But there's also two other ways in which women may enter menopause, and this might be more applicable to some of you in this room. There can be surgical menopause, which is essentially where a woman has had to have her ovaries, and typically we don't take the ovaries without the uterus, so ovaries and uterus removed for any number of reasons. It can be cancer risk, it can be any number of gynecologic conditions, but anything resulting in the sudden cessation of hormone function due to surgery. And then medical as well, which is typically induced through medical treatments. Many of the cancer treatments, whether it's chemo or radiation, can have toxic effect on the ovaries and cause permanent menopause. So sorry that I'm symptom-wise, what menopause tends to present like, and I want to kind of help you understand that menopause is not necessarily, while menopause is a destination, it's that final cessation. Getting there is sort of a process. So if you go through natural menopause, it might not, look like this all at once, but these symptoms can start in the perimenopausal stage. So anywhere between 1 and 10 years prior to the cessation of periods. So hot flashes and night sweats are probably the most common. Also vaginal dryness probably should go in those top 3. But we also start seeing things like worsening of depression or anxiety, or new onset of depression and anxiety. Brain fog is also super common, joint aches and pains, sleep disturbances, low libido, and painful intercourse. So lots of fun, right? Sounds like something everybody wants to do. So treatment option wise, we kind of have them broken up into 2 categories, non-hormonal and hormonal. Non-hormonal tend to be things like the lifestyle changes. We have antidepressants, SSRIs or SNRIs, that we use typically for anxiety, depression, but also some of the SNRIs work really well for hot flashes as well. Gabapentin, which is a medication used oftentimes in neuropathic conditions, also works well for hot flashes. And then we have a medication that actually works on our thermoregulatory system called Veoza. And then, of course, hormonal options, estrogen. Estrogen by itself for women who've had a hysterectomy, but estrogen and progesterone in combination for women who still have their uterus. And those can come in oral form, taking pills, or transdermal is a very popular option right now. It's typically a transdermal patch that is placed on the skin, a gel that's rubbed in, or a spray that's sprayed on the skin. And then we also have vaginal hormones, typically used for symptoms of vaginal dryness or painful intercourse. Those can look like vaginal estrogen, or there's even vaginal DHEA, which is a precursor hormone that then your body changes into estrogen and testosterone. So those are the main treatment options that are available. And we'll go a little more into the lifestyle ones a little bit later. Surgical menopause is its own unique beast because it is somebody who literally goes from having estrogen to having no estrogen in a matter of a couple of hours, and it can be pretty intense. These people typically have worse symptoms than people who go through menopause naturally, so it can be really challenging. For women who go through surgical menopause who are able to do so, we immediately put them on estrogen replacement therapy. Oftentimes in younger women, for me, women, younger than 40, I'll also put on a form of testosterone just because at that stage of their life, their ovaries are still producing quite a bit. So it's also a sudden shift for them. Vaginal estrogen can also be extremely important in this stage. Vaginal estrogen is interesting because oftentimes even when we replace systemic estrogen through a patch or a pill, it's not always enough to cover those vaginal symptoms. So oftentimes women need additional estrogen for the vagina. So that typically looks like a cream that can be inserted, or a tablet, or there's also a vaginal ring that just sits up inside the vagina and helps with lubrication and moisture. And then also it's really important for people who go through surgical menopause to have surveillance of their bone density. Estrogen is really the leading hormone for women that supports our bone density. So the longer we go without estrogen, the more at risk we are for having bone loss. So those are the main things that we think about whenever somebody is going through a surgical menopause. So I wanted to talk about the role of hormones in cancer. You guys could probably teach this lesson for a lot of you who've been through a cancer with hormone receptors. But all of our cells have different types of receptors, including hormone receptors. Normal cells as well as cancer cells can have them. They're just little proteins that sit on the cell and wait for the proper hormone to come and sit in that receptor and activate it. So our female organs in particular, so the ovaries, the uterus, and the breast, all have hormone receptors, and it's part of their normal growth pattern. But cancer cells can also have hormone receptors, and when those hormones sit in that protein, it activates those cells to grow. So what we don't know in any given individual is who has these cancer cells that have hormone receptors and who don't. So exposure to those hormones over time can increase risk. But most of our female cancers will have some amount of hormone receptor, and we'll kind of look at that here next. So breast cancer is the most common one that we hear about. 80% of breast cancers are estrogen receptor positive, and 50% of those are estrogen and progesterone positive. The percentage of progesterone receptor positive alone hasn't really been quantified, but it's really low in comparison to those two. Uterine cancers in particular, type 1 uterine cancer, about 90% of those are estrogen or progesterone receptor positive. And then ovarian cancer, in particular, the serous type, 87% of those are estrogen receptor positive and 56% of them are progesterone receptor positive. So that kind of helps you understand a little bit about why we care about this. When somebody has a hormone receptor positive cancer, they have a few different options. There can be surgical removal of the uterus and ovaries to stop the body's own production of those hormones and minimize exposure. This is often done. It can also be done prophylactically for women who might carry BRCA genes and are at higher risk. They may opt to have their ovaries removed. But it also happens often through hormone blockade or what we call endocrine therapy, which is just different types of medications that either stop the body from making estrogen or block the effects of the estrogen in the tissue. How many in here, by the way, have had a hormone receptor positive cancer? Okay. Preaching to the choir then, huh? You guys know a lot about this, I'm sure. Hormone blocking medications, they're developing new ones all the time. I just was reading about some new ones today. Most common ones we see are the aromatase inhibitors. Arimidex, Aromacin, and Femara are the most common ones that we typically see. Those are typically used in women who are already menopausal at the time of their breast cancer. The SERMs or selective estrogen receptor modulators are actually more often used in premenopausal women, so tamoxifen, Evista, and Ferristin. I have never known anyone to take Ferristin, so if I'm saying it wrong, you guys can correct me. And some newer medications are the SERDs, which are Faslodex, and another one that's Orserdu. Hopefully, that's what it's called. Side effects of hormone blockers might look quite familiar to you because they're pretty much the same things that showed up in our menopause symptoms. Hot flashes and night sweats, mood changes, vaginal dryness, joint aches and pains, osteoporosis, and risk of blood clots. How many of you experience these types of side effects with your endocrine therapy? Yeah, quite a few. I see women in our clinic all the time that are experiencing these types of side effects from their medication. And the biggest challenge that I think we have as providers and as a medical system, sometimes we get so focused on cancer survivorship. We're just like, you should just be lucky to be alive. We've got these treatments that can cure this cancer or prolong this course, but then quality of life can sometimes be really strongly impacted by these medications and treatments. And so I'm always thinking about ways in which we can make this easier for women to go through. So intersection of menopause and hormone receptor positive cancers really comes down to the fact that if you are menopausal, or if you have all these menopausal symptoms from your endocrine therapy, the option to take that hormone therapy to resolve those symptoms isn't available to you, or at least not at great risk. And so that's where our biggest challenge lies when it comes to these specific types of cancer. Because especially right now, I've had a lot of cancer patients come to me and be like, this just really isn't fair. That menopause is so in our media right now, and everyone's talking about it. It's all the buzz, and all their friends are doing it and feel amazing. And what about us? I'm not able to do that. So what am I going to do then instead to get the same benefits that our other people that aren't cancer survivors are able to do? So our treatment options for women who have had a hormone receptor positive cancer typically fall into this non-hormonal category. Those antidepressant serotonin receptor, selective serotonin receptor inhibitors for depression and anxiety, the SNRIs, gabapentin and oxybutynin for hot flashes, as well as Veoza. The downside to non-hormonal options is that they're targeting specific symptoms. So unlike having the umbrella of hormone therapy that tends to cover a lot of symptoms with one medication, we tend to have to go after specific symptoms. And for each of you, it may be a little bit different. Some people have severe hot flashes and night sweats that are impacting quality of life and need that targeted. I know a lot of women have joint aches and pains that may be really severe with their endocrine medication. So it really pushes us to think outside the box a little bit and to be a little more selective. I tell people it's one of those things sometimes where we really just have to look at what is causing the most significant impact on quality of life and go after those things first. And certainly there's always the option of trying different endocrine therapies if one isn't working as well for one individual or causes significant side effects. Changing to something else might do better. I put on here hormonal vaginal estrogen. Many of you may know that vaginal estrogen has proven to be safe even in hormone receptor positive cancers. So I actually really encourage women as soon as they start their endocrine therapy to start a vaginal estrogen. Vaginal symptoms are one of those things, a little bit like pain. Once it's started and you're trying to play catch up, it can be a bit challenging. So if we can stay on top of it early on, then we can kind of avoid some of those major setbacks that people then have to spend a lot of time resolving. I have a patient currently that didn't know there was any option for her and went through several years of really struggling with vaginal dryness and painful intercourse. And by the time she came to see me, I mean, intercourse was completely off the table and she was just absolutely miserable. And it took us probably 8 months to really get her to a place where she could tolerate any sort of penetration. And so I always feel heartbroken and wish that our our educators were better at really thinking about this for women, because it really is something we can be proactive about. And again, for me, my PhD is sexual medicine, so this is something I think a lot about. How can we retain as much sexual function as possible for women? And this is a really simple thing that women can do. I do every once in a while have somebody who just really doesn't feel comfortable doing any type of hormone therapy. Just the idea that there's estrogen in it can be really disconcerting for people who've had a hormone receptor positive cancer. And in that case, sometimes we'll use things like vaginal DHEA, which the body will turn into some estrogen and testosterone, but some people feel more comfortable with that. Or we do have a couple of other non-hormonal options that don't necessarily work quite as well, but there's always over-the-counter vaginal moisturizers and things like that that can be used before if people are reluctant to try an estrogen. But estrogens are very safe, and I do want to shout that from the rooftops. So, okay, I want to end menopause stuff there. Questions that you guys have about all or any of that? Yes, please. You said about 52 is the average age, right? And so do we still need HRT if we ended? So if our periods have stopped, do we still need HRT or AI? The AI. Do we still need medicine for that? Do we still need hormone replacement therapy? Yeah, great question. So typically you're on aromatase inhibitors because you've had a hormone receptor positive cancer, correct? So those women typically are not eligible because the risk of them using estrogen or progesterone therapy or both in combination puts you at higher risk of having recurrence of your breast cancer. So oftentimes that's when we utilize those non-hormonal options to try and meet the same benefits without using hormones. So I would say, oh, go ahead. Yeah.
So yeah, I was triple positive.
Okay.
When I was young, so I went through menopause, but now I'm in my between 50s and 60s, definitely on period. I don't want to continue with that therapy, so I was just wondering.
Oh yeah, yes, makes sense. For some women who go through younger, I feel like data is still really emerging around, where it might be safe to start considering the addition of some hormone therapy. I do have a handful of women who've had cancers remotely, meaning 10 or more years in the past, who've completed their endocrine therapy, who have then talked with their oncologist and decided that they may benefit from doing some hormone therapy. Oftentimes for those individuals, I will use a medication called Duave. There was a recent study that was done on Duave, and they looked at Duave and DCIS. I don't know, has anyone in here, did you have DCIS as your diagnosis? So ductal carcinoma in situ, there's still a little bit of argument in the oncology realm about whether or not it qualifies as an actual stage of cancer or if it's a pre-cancer in the breast, because it's technically cancer cells that are found inside the cell and have not broken through. So it's essentially like a pre-cancer. But they actually did a trial called the Promise study, where they actually gave women who were diagnosed with DCIS this medication called Duave. It's an estrogen in combination with a selective estrogen receptor modulator. And they actually quantified the number of chemicals that essentially show tumor growth. And they pre-treated these women before surgery and after their biopsy. So they quantified them with the biopsy, they gave them the Duvet, and then they quantified those again at the time of surgery and actually found that the Duvet decreased the number of these chemicals found. So they call it the PROMISE study because it is promising in terms of its potential benefit and protection for the breast while allowing some use of estrogen. It's now obviously going to stem a lot further studies, but for those individuals with DCIS, it may offer an opportunity to use some hormone therapy that wasn't there before. So, but for the most part, it's a conversation that I encourage every woman to have with their oncologist because everybody's situation is unique. And for some, you know, if they have had a remote cancer more than 10 years ago, you completed your, 5 years of endocrine therapy. For some women, it's risk and benefit for them feels like it leans more toward doing some type of estrogen therapy at that point. I never make that decision by myself. We have these conversations often with the oncologist at Huntsman, and it's very much individualized in terms of who that might be the right decision for. Yeah.
I have a couple of questions.
Yeah.
You mentioned you had a woman come to you that didn't even know vaginal estrogen was an option for her.
Yeah.
She was way far down the path.
Yeah.
Is there a demographic of women that you tend to see who are maybe uneducated or ignorant about that? And then you also made a comment that you wish our educators would talk about it more.
Yeah.
Is there a group of educators that you would like to see bring it up more that we almost take for granted?
Sure.
They were talking about it.
Sure. Yeah. Great questions. So I would say demographically, I sometimes feel like I see this more in women who were not menopausal at the time of their cancer diagnosis and were thrown into menopause due to treatment. And I don't know if there's a specific reason why they didn't gain the education. I mean, most of the cancer patients, honestly, that come to me were like, oh, I totally did not know you could do vaginal estrogen. So I don't know how much it's being talked about in any demographic with the educators. I sometimes think, in all honesty, and this is completely understandable. I think that, again, the focus initially on diagnosis and treatment is all about survivorship, right? We want to get people through these treatments. We want to get their cancers treated and into remission. And the focus is more on that than on what is life going to look like for this individual after their cancer has been treated. Does anyone agree or disagree? I'm like happy to, because you guys have been through this, so more. I'm on the front lines of my own clinical experience, but you guys know what you've experienced in terms of your own situation. Was it something that was addressed at all? Was sexual function ever something that was mentioned? Way later, yeah. Unfortunately, right, yeah. Unfortunately, oftentimes that's the case. It's either something you bring up or it's something all of a sudden now I'm starting to have these concerns. And now, yeah, exactly. Now we're going to address it because you're miserable. Yeah. And then your second question was about which specific nurse educators. I think most of the oncology clinics that I have interacted with have nurse educators. So I know in talking to a lot of the oncologists, they make the assumption that a lot is being discussed by the nurse educators. And I don't know how much they really collaborate. I'm sure they do at some point, to say, hey, I think this is important for our patients to know. I worked for a short time, once upon a time, in radiation oncology, and I still interact and communicate with the physicians I worked with in that practice. And they were kind of like, we just assume that's done elsewhere, and they don't necessarily feel the urge. Even after me bringing it up, they were like, yeah, it's still not something we're going to really worry about. So I'm like, really? That stinks. Okay. So I would, in an ideal situation, and I have no idea, honestly, how a lot of the systems, I feel like Huntsman's kind of the big system here. Utah Cancer Specialists is out there. Is Revere Health, I think, maybe down central Provo, central Utah. I think they're the big kind of cancer group down there. I don't know how, collaborative those individuals are in terms of, do the nurse educators meet with the physicians? Do they talk about the things that their patients are experiencing, or do they kind of just have a checklist? I don't really know. So great question, worth investigating. So.
Yeah, I think that all of the disciplines and specialties are so many other ways.
For sure, yeah.
If they're male or female, that's thing where like, oh, that's not in my pay grade. Like,
yeah.
I talk to someone else about it. I don't have time, and I just feel like, I mean, I didn't have a nurse navigator in my process, but it just seems like if there's one more specialist I have to see,
yeah,
right.
About
if I'm going to live or not, it would be nice if someone would just take that on and be willing to.
Yeah. Yeah. I don't know. And I found it super interesting. And I don't know if this is just my own unique experience, but when I was working in radiation oncology, my 2 physician providers were both male. And both of them told me that their male patients would ask them like prostate cancer, things like that. They would talk to them about sexual function, but they said their female patients would never talk to them about it. I'm like, that's funny because they talk to me about it all the time. So I don't know if it's just approachability is part of it, and in some cases, it's really difficult. It's hard for us to understand another gender's experience. And so it might just be more challenging for them to put themselves in the shoes of somebody who might be experiencing this and what that's like. Sex for a long time, sex in particular, has been viewed as a luxury. And so if you get to have it, great. And if you don't, no big deal, But for a lot of people, it's a very important part of their lives, and they don't want to have to end that just because they receive a cancer diagnosis. So, yeah, go ahead. Yeah. Yeah, I can bring it back.
Because you're always weighing out side effects.
Sure.
The benefits. And so in your experience with patients, what have you seen?
Yeah. So I would say SSRIs, obviously they do a great job for anxiety and depression. Certainly the biggest challenge we have with SSRIs in terms of women's health is that they do often have significant sexual side effects. For some people, that means just really diminished libido, no drive or desire for sex. For other people, it's more arousal and orgasm side effects where they're not able to fully be aroused to orgasm. So those are definitely something that you have to consider. SNRIs is typically like your Effexor. I know Effexor and Paxil historically have been used a lot for hot flashes in cancer patients. They are pretty well tolerated overall. So they tend to be my go-to if I am picking options specifically for hot flashes. Gabapentin it can cause a lot of dizziness, tired, sleepiness, drowsiness, that kind of thing, and it can also cause weight gain. So it is definitely most people's not favorite. Oxybutynin is a medication that was originally used for, and it still is used for like overactive bladder or people with like urge incontinence. It tends to cause side effects of dry mouth, dry eyes, and some vaginal dryness as well with that. Veoza is super well tolerated. It actually works on our neurokinin B receptors that actually regulate our body's thermostat. The downside to Veoza right now is that it is really expensive. It's newer on the market and there's no generic. So oftentimes it's a lot of prior authorization. Usually the insurance company comes back to us and says, well, they've got to try A, B, and C before we're willing to pay for this. The good news, however, is that Bayer Pharmaceuticals has a comparable product that they have received FDA approval for that was supposed to be released in August, and I think they've pushed it back to October. So we'll see. You never know how these things are going to pan out, but their plan was to release it immediately at a generic price point. So, yeah, I mean, yeah, it is. It's a very big deal because Veoza is really expensive. Yeah, go ahead.
Can you talk or put some numbers to the risk of recurrence for people who had estrogen positive cancer using an estrogen vaginal cream?
Oh gosh.
I understand everybody's
Yeah.
but
I can tell you absorption wise. So mainly what we're looking at, right, is when we use a medication, are we getting systemic uptake of that medication? Because in order for us to have estrogen to fit into that receptor, there has to be estrogen flowing through the body. And the systemic uptake of vaginal estrogen, the way we dose it, which is twice weekly, there was barely any traceable blood level of estradiol. So that's really what they've looked at. I don't know that I've seen any specific numbers on recurrence because they just haven't seen the systemic uptake that would, result in a recurrence. I know there are more specific numbers, and I did not prepare them for you today, more about obviously like using hormone therapy and recurrence, because then you are flooding the system with these hormones, and those receptors that still may be present in the body can take those up. But with the estrogen, when they looked at the blood levels, there was just not a significant quantifiable level from the vaginal estrogen. So hope that helps. Any other questions about this? We can transition towards sexual specific things if that's, yeah, go ahead.
do you have a go-to for patients that you have that are triple positive and were surgical and medical menopause and have done the things and they aren't working?
Yeah.
Do you have a go-to?
Great question. Yeah, it can be tricky. It really, I have I kind of have my own algorithm of things that I tend to try. In those cases, Veoza is really going to be the one I'm going to push hard for, especially if hot flashes and night sweats. Oh, great question. Yeah. I know, right? Yeah, there are these issues. Because Veoza, that is the downside, is there's a liver impact. This is metabolized through the liver. We check liver enzymes before starting. We check them during treatment. So from a pancreatic standpoint, it can be really tricky. I think I must have left my slide out that talked about lifestyle changes. Obviously, lifestyle can be a big part of things. One of the things that we've looked at at the university, Dr. Moreno has headed up our Menogap program, which basically looked at the use of some alternative treatments for these vasomotor. You're like, yep, done that too. Because acupuncture had some pretty significant, at least statistically significant results in terms of hot flash relief. There's no perfect answer, to be honest, because oftentimes we're weighing one thing against another, right? Like gabapentin might work really well and we have to tolerate side effects. Is that worth it? It's such a challenging decision to be made. Honestly, at that point, depending on your own situation, depending on any individual situation, a conversation around Duave would be worth having with your oncologist. Again, that's the newer medication. It's a conjugated estrogen, so it does have estrogen in it, but they combined it with a medication that actually blocks estrogen activity in the breast and uterus. So it's promising. We don't have enough data yet, but I do have a handful of breast cancer survivors that are more than 10 years out from diagnosis that are using Duave because for them, quality of life was more important. But we don't have any data right now around recurrence with Duave. All we know is that it does seem to diminish the number of those chemicals that target the change of the cells. So maybe something in the future, but you're in a really tough spot sometimes when you've gone down that checklist of things and nothing's really working. So I feel for you. It's a struggle. And sometimes a combination of things can work too. You know, sometimes if somebody can tolerate a low dose of gabapentin in combination with Effexor, I sometimes will do that combination. So sometimes people feel like the side effects from gabapentin aren't as severe when we combine it with Effexor. So it's worth looking at if you haven't tried them together. But you're in a tough spot for sure. Any other questions? Yeah, it is DUAVEE. So, and it's another one I actually was trying to get it approved for a cancer patient just recently, and the insurance denied it, even with her diagnosis of history of breast cancer. So we're in the appeal process to try to see if we can get it covered, because I think they definitely want to say you got to try that whole list first. So. Okay, I know you guys have another presenter, so I don't want to take too much time. If there's any other questions or if you have specific, I do have one more thought in terms of sexual health, because I don't know how many people in here fall into the category of having received pelvic radiation. It's another passion point of mine. I wish every woman who started pelvic radiation, no matter what the cancer was, whether it's rectal cancer, colon cancer, uterine cancer, vulvar cancer, whatever, anybody who's receiving cancer or receiving radiation to the pelvis, I wish every oncologist would send them to pelvic floor physical therapy before they start treatment, put them on vaginal estrogen, and having them use vaginal dilators the entire time they're going through treatment. A lot of women who go through pelvic radiation completely lose any functionality of the vagina, because the radiation really causes some changes to the tissue that then it doesn't stretch well, and it fibroses significantly. And I know several women who've gone through it who are no longer able to have any sort of penetrative sex. So it's my passion point. I'm like, again, tell everyone, if you know anyone who's going through that. And I've tried to tell the oncologists that I interact with, please do it, because in most of those pelvic cancers, there's no contraindication to vaginal estrogen. Go ahead.
Do you mind repeating the types of people who may be undergoing pelvic?
Yeah, so it typically is any type of lower bowel cancer, so rectal, anal, colon, uterine, vulvar, cervical potentially, and my brain just left the building, so hold on. It can be, any sort of lymphoma that may be presenting in the pelvis as well. So really anything from, here to here that's going to be radiated, there definitely needs to be that discussion on board. And again, I know that surviving this initial diagnosis is really important. I think that's extremely important as well. I also just want people to be thinking about quality of life after treatment. So, okay, thank you so much. Oh, yeah, go ahead.
Do you typically have to fight pretty hard to get pelvic floor therapy covered for people?
No, I feel like nowadays, initially, before pelvic floor therapy became, as mainstream as it is now, there were a lot of pelvic floor therapists that did not take insurance, and that was an issue that we ran into quite a bit. But now, University, our system has pelvic floor PT, IHC system has pelvic floor PT. There's a lot more that are taking insurance, and, I very rarely run into pushback on that particular thing. Of all the things that insurances choose to push back on, that's not typically one of them. So, okay. Yeah. Yes, technically it's just for women right now who have a uterus after this PROMISE study. So oftentimes what happens with a clinical trial is that they do this trial, they find out that it works well in one setting, and then they'll start looking at it for other settings. So the reason they said that was originally because the struggle that women had is that the higher risk of breast cancer is when women are taking estrogen and progesterone together. So to eliminate the progesterone out of that equation would help reduce that risk. But then they did find that that did block the estrogen effect in the breasts. So further clinical trials are now stemming from this original study. But I think future-wise, there won't be that requirement. It's sort of like a lot of medications we have that are approved for premenopausal versus postmenopausal. It just takes time sometimes for those to, but I think we'll start seeing it used off-label for women who do not have a uterus. So, okay. All right, well, thank you.